and or afternoon. Good morning and or afternoon, depending upon where you are in the world. Welcome to today's session. My name is Tammy Sadowski. I'm the Senior Director of Diversity, Equity, and Inclusion at Inovalon, and I'm proud to lead this panel discussion and conversation around how to bridge the gap, how we can help as a company to overcome healthcare disparities in communities of color. If we move to the next slide, I'd like to introduce everyone who will be speaking today. So Dr. Jocelyn Hines, Dr. Paige Kilian, Denise Alexander, Jamal Wilburg, and Melanie Brooks are our panelists for the panel discussion that we will have later on today. I will be primarily the moderator, and I will share that with everyone who you see here on the screen. And then Spencer Brumfield will also be sharing a bit about our job opportunities and how each and every one of you could have the opportunity to do the important work here that we do at Inovalon to help bridge those gaps in communities of color. Do each and every one of you want to take a moment and just introduce yourselves and give us your job title, starting with you, Jocelyn? All right, we'll hop to you, Paige. Maybe Jocelyn's having some technical difficulties.
Hey there, I'm Dr. Paige Kilian. I'm Inovalon's Chief Medical Officer, and I'm happy to be here.
Denise?
Denise Alexander, Senior Project Manager, supporting the information technology area.
Jamal?
Jamal Wilburg, Vice President, Customer Support for our Provider Cloud.
Wonderful. Melanie?
Hi, good morning, afternoon. My name is Melanie Brooks. I'm a Senior System Administrator. I also work in IT asset management as administrator there too. Nice to meet you guys.
And Spencer.
Hi, everyone. I'm Spencer Brumfield, AVP Talent Acquisition. I'm happy to be here and nice to meet everyone.
All right, if we move to the next slide, we'll get started with what we're going to talk about today. So here's our agenda. We're going to tell you a little bit about Inovalon, who we are as an organization and what we do. Then we will transfer into a little bit about our data and how that data, with some real live scenarios of how that data can impact individuals' healthcare outcomes. Then we will host our panel discussion. Then we're going to talk a little bit about what it's like to work at Inovalon. And if we have the opportunity, we're going to open it up to Q&A at the end of today's call to answer any questions that you might have. Next slide. Jamal, I'm going to pass it over to you.
Thanks, Tammy. I get the pleasure of introducing Inovalon to all of you. And Inovalon is a leading provider of cloud-based software solutions, empowering data-driven healthcare. We believe that data can dramatically improve the outcomes and economics of healthcare. From payers and providers to pharmacy organizations and life science companies, anyone in healthcare can benefit from the innovative capabilities of our solutions powered by the Inovalon One platform. As a testament to Inovalon's differentiated capabilities and proven experience and results, the company's reach spans across the healthcare ecosystem, where we support most of the top health plans with the converged SaaS solution suite, provider systems with one single sign-on, easy-to-use portal, global pharma and pharmacy companies with ScriptMed end-to-end workflow software, as well as helping life sciences companies harness the power of healthcare data. Our primary source healthcare data set is the largest in the industry. The significant size, extensive breadth, historical duration, recency, and fully linkable primary source nature of this ever-expanding data set provides a uniquely rich source to inform our analytics, differentiate our capabilities, and empower our customers. The Inovalon One platform brings together national scale connectivity, real-time primary source data access, and advanced analytics to enable improved clinical outcomes and economics across the healthcare ecosystem. Our analytics and capabilities are used by nearly 20,000 customers and are informed by the primary source data of more than 73 billion medical events across 1 million physicians, 631,000 clinical settings, and 362 million unique patients. And with that, I'll hand it over to Denise to talk about our broad in-house technical expertise.
Thank you, Jamal. The individuals who work at Inovalon represent a wide variety of professionals, including corporate roles, medical professionals who provide input to our platforms. Our experienced staff comes from well-known organizations such as Target, Amazon, AWS, Microsoft, Optum, and Avaya, to name a few. Inovalon's connectivity, data, and analytics would mean little, however, if it weren't for the many talented and dedicated associates that make up our product, engineering, and security teams. Our software solutions are designed through a combination of in-house data management, technology expertise, and the knowledge of subject matter experts who understand the healthcare landscape of today and how to prepare for tomorrow. I'll turn it back over to Tammy.
And so we're going to talk a little bit about how we bridge that gap. We're going to give you some important information about our data. We're going to share some real world scenarios about how that data could provide the opportunity for better healthcare outcomes for patients. We're then going to enter into our panel discussion where each and every one of our panelists are going to share some personal experiences. And then we're going to talk about actions that you can take to help improve your own personal healthcare outcomes. So if we move to the next slide, I'm going to pass it over to Paige.
Thank you, Tammy. All right, so why are we so focused on inequity in healthcare outcomes? And why do we keep saying data are so important? It turns out that when you look at healthcare outcomes, only 20%, are attributable to clinical care, meaning the quality of the care you receive, the access to care that you have. 80% of healthcare outcomes are due to other stuff. So socioeconomic factors, health behaviors, physical environment, for example. Next slide, please. Okay, so why does this matter? It matters because we want to improve. And there's an adage that you can't improve what you can't measure. And that's the rub here, because the fact is that most traditional healthcare outcomes are analyzed looking at claims data. And that's how we tell what happened, and that's how we tell what might have led up to what happened, and a little bit of electronic medical record data too. But those two entities do not adequately encompass, for the most part, those social determinants that I mentioned in the prior slide. So this is starting to get better. There's a lot of emphasis on the importance of social determinants, of documenting it in the medical record, and of getting it into the claims record through Z codes, but we're not where we need to be yet. So how do we overcome the gap in social determinant data? Well, where we have average socioeconomic data for geographic areas at the country level, at the state level, at the county level, at the 5-digit zip code level, we can impute that average information down to the individual resident there and start to build out a little bit better picture in conjunction with the healthcare data that we have access to. So the picture of the individual might be a little bit blurry, but it's still better than if we only had the healthcare data that was coming from the electronic medical record or for claims data. And if we have those average data at the 9-digit zip code level, now we can form an image that has a lot more clarity when we're considering who the average resident is and what her barriers might be and where we might need to funnel dollars for transportation or to build more neighborhood clinics or to deliver prescriptions or to deliver food. Next slide, please. So as we start aggregating patients into these geographic regions, we can draw some big conclusions. So here we've used an example of medication adherence, and you can see that there are wide geographic differences in how easily people are able to take their medications as prescribed, and taking your medications as prescribed is an important indicator of how outcomes are going to flow. And if we can improve people's ability to take their medication as prescribed, we can improve outcomes. So where we see these big differences geographically, we can start to drill into the data to figure out what the real contributors are. And again, where do we put the data? Where do we put the dollars to try to overcome those barriers? Next slide, please. And here are the data elements that Inovalon uses to help its clients to do just that. We can help shed light on where the barriers are, so those dollars can be targeted exactly where they're needed and exactly where they're likely to have the most effect. Next slide, please. Using the data elements on the previous slide and combining those with medical data from claims from the electronic medical record, Inovalon helps its clients overcome the barriers and helps close those disparities, close the gaps in healthcare outcomes. And Dr. Hines is going to walk us through a few scenarios to illustrate some real world examples.
Thank you, Dr. Kilian. Dr. Hines, are you out there?
Yes, I'm here. So let's just go through a scenario, right? So we have Janice. She has sickle cell anemia, and she's been given a prescription for an expensive medication to help mitigate her symptoms. Her local pharmacy does not have the medication that she needs, and she must travel 45 minutes to pick up the medications. Now, as we were talking about in the context of medication adherence, imagine if you've got to travel 45 minutes to pick up your medication. That's a barrier to staying compliant, right? And that's assuming that she has the transportation, that there's not a cost to getting there, that the pharmacy has hours that are compatible with her work schedule, those kinds of things. So what could the data from Inovalon do to provide Janice's doctor or health plan with the information needed to help her? So as Paige was saying earlier, when we have information about the demographics and the indicators in a population level environment, we can figure out that, hey, the health plan might need to know we might need to partner with other pharmacies in this particular demographic area. We might need to get other specialty pharmacies involved so we can get these medications to Janice at a more reasonable price, because we said it was expensive medication as well. So those are the kinds of things that having the data can enlighten the health plan, hospital networks, and things like that to do, so that we can get patients better access to care. Let's look at scenario number 2. In scenario number 2, we have Daryl. Daryl seems healthy. He works out frequently. He eats lots of fruits and vegetables. He's been feeling tired for the last several months and is kind of losing his appetite. His wife insists that he go to the doctor, but Daryl says, oh, this is just part of getting older, or, oh, as long as I can go to work, it must not be that bad, or, oh, let's just give it some time. I'm sure it'll go away. I think many of us may know some Daryls, right? So he waits almost a full year before going to the doctor because he can't afford to miss work. Ultimately, he is diagnosed with liver cancer, which his doctor feels is treatable, but he must stick to a strict and expensive regimen. So this is another instance where access to care and engaging with care can be a barrier. So unfortunately, people of color are more likely to be diagnosed with cancers at more advanced stages. And as you can imagine, the more advanced the stage, the harder it's going to be to treat. But for example, data from Inovalon could help Daryl's healthcare team, one, get him medications that he might need. Also, make sure that we're identifying outcomes that are different in different communities. So for example, are the outcomes in Daryl's community for cancer and cancer treatment are the same? Are equitable treatments being distributed? Are cancer outcomes coming out similarly? Those are the things that data can help us target so that we can get at some of these disparities in healthcare outcomes that I think many of us are familiar with.
Thank you, Dr. Hines. All right, so if we move to the next slide, we're going to begin our panel discussion. I'm going to read each panelist a question, and they're going to be sharing personal experiences about their own interactions perhaps with the healthcare system or outcomes that have occurred for them. So we're going to start with you, Dr. Hines. Inovalon technology can be used to address racial disparities in healthcare. As a physician, can you share some ways that our provider network can use our data to make decisions in a more equitable way, leading to helping to bridge that gap for underrepresented communities?
So I missed, I was having some technical difficulties earlier, but I'm a family physician by training. And as a provider, lots of times you assume that your population, your patient panel, the people that are coming to your clinic and the care that you're giving is unbiased and normal. As many people may be aware, there are things called implicit bias, which is bias that we're not even aware that we have. And some of that may play a factor in why there are different outcomes for different groups. So data can help a provider see, hey, it seems like my Black patients have higher blood pressures than some of the other patients in my cohort, right? Or maybe it looks like this particular group isn't getting the same number of follow-ups that some of the other, participants in our clinic group are getting. Or this provider's having different outcomes than another provider all in the same group. Data can help you see the things that you may not even realize are a problem and put them into a way that we can measure so that then we can improve. So Inovalon's data can help providers see where they may not be giving the care that they think they are, not necessarily on purpose, but because maybe there are some additional resources that need to be funneled so that their population is getting equitable care.
Thank you, Dr. Hines. Dr. Kilian, as we look at healthcare disparities, outcomes for Black patients with chronic conditions like diabetes and hypertension are less favorable. What do you think contributes to these outcomes?
So this is a really big question, and I'm going to try to answer it succinctly, but yet give it the justice that it deserves. If we talk about hypertension, for example, on its own, there are two kinds of disparities that we see: disparity in prevalence of the condition and prevalence in control of the condition. So that means hypertension in this country occurs more frequently in Black adults than it does in white adults. The numbers are around 57% versus 44% on average. So why is that? It certainly is, that there are socioeconomic factors that contribute. So things like poverty and inadequate access to education and inadequate access to good nutrition can be risk factors for hypertension. Interestingly, so is low birth weight. So low birth weight is overrepresented significantly in the Black population in this country, and in and of itself is a risk factor for hypertension, as well as for other things like obesity and depression. So you're kind of starting behind the 8 ball, for lack of a better analogy. Interestingly and sadly, in regions and other countries where there's less disparity between Black and non-Black populations, less socioeconomic disparity, that prevalence gap largely resolves. With regard to control of hypertension, there's a significant difference as well. One large study found that 75% of white adults with hypertension had their blood pressure adequately controlled versus 64% of Black adults with hypertension. And some adjusted analyses of those data indicate that about 30% of the contributors to that disparity are related to socio-demographic factors. We have to identify what those factors are, and work to overcome them, but we also have to identify the other contributors and then solve for that. I want to touch on one more thing that bears further scrutiny and is a major observation, a major tragedy, I think, in our country. Among Black immigrants to our country, the average life expectancy is 8 years longer than Black residents who are born and raised here. So what role is the Black experience in our country itself playing? It's complicated. There are a number of schools of thought around it. I want to touch on two that are not mutually exclusive, but that are important. One is the early programming model, and one is the accumulative stress model. In a nutshell, the early programming model acknowledges the fact that early childhood exposures, early childhood situations like low birth weight, like exposure to lead, like improper nutrition, can lead to health consequences down the road in adulthood. The cumulative stress model acknowledges that chronic stress in and of itself is harmful to health. It affects your body's ability to cope, and you end up with a higher propensity for hypertension, for diabetes, for obesity. So taken together, the implications of these models show that there's more to the Black experience in America and the impact on health outcomes than we have a clear image of. We have to solve it. And in order to solve it, we need data.
Thank you, Dr. Kilian. I have to be honest that some of that information is quite sobering. But let's continue to learn ways that perhaps we can overcome this. Jamal, when we speak about healthcare disparities, what is your experience when it comes to healthcare?
Yeah, thanks, Tammy. I think this is a bit of a complex one for me because on the surface, I feel like, well, I don't run into some of the disparities in the healthcare as I go through my day-to-day life, but it's just a reminder of, I've got the privilege of having a doctor's office, a multi-specialty practice, and grocery stores all within a 10-minute drive of my home. But as I drive through the community, I know that everyone doesn't have that. And I see people that might be able to make it to that first appointment, but if they get referred to a specialist, that's another day and time they have to take off work. And I hear, friends and family contemplating the cost of that visit versus are they really sick, and the decisions that people make in their care. And in the peak of the COVID pandemic, seeing it firsthand with family members of not wanting to go get seen, not wanting to get treated because worried about the cost that could come out of it over their overall well-being and health, and waiting until the absolute last minute to go get a test or go see a doctor or go to the hospital. And personally, those have worked. Everyone's been okay, but I know so many people that have not had those good outcomes in those moments of waiting until the absolute last minute to get seen versus the preventative visits. And I see it all the time, and it's not fun. It's not something you enjoy looking at as you drive through and realizing, people that don't have access to a grocery store or other things like that. But I've been personally fortunate to have a really close friend group that we message each other and say, when's the last time you've had a physical or you've gone to the doctor and handled those things, so that we can try to, at least within our small group, overcome some of those disparities for each other.
Wonderful. Thank you, Jamal. Denise, as we discuss healthcare disparities, the theme of a lack of adherence to regular doctor visits or not regularly taking medications has come up multiple times in the Inovalon data set. Can you share a personal experience where you chose not to engage with medical care?
Thank you, Tammy. Yes, I can. And I know I'm smiling. This is not a topic that we should smile about, but I do have a recent story, so I'd like to share with everyone. So on March 28th, 2023, my young neighbor, a second grader, and I went out for a walk. We had become walking buddies. Our target was at least 1 mile for my sake, and sometimes she would ask to walk farther or do little challenges. On this day, the first half mile was normal. We then progressed into some challenges, moving from walking to fast walking to skipping, then running. I won the last race, so she makes up one last challenge: to hop on 1 foot to the tree. I can't say no. Here we go. 1, 2, 3, go. And off we went, hopping on 1 foot. She starts switching feet and coming into my lane. I remember thinking, don't crash into her. Hop, hop, we're tied, almost to the tree. Up ahead on my side, a crack in the sidewalk. Uh-oh, hop, hop. Oh my gosh, I rolled my right ankle. I stand motionless. Excruciating pain radiated from my foot, up my leg, throughout my whole body. The pain paralyzed me. All I could do was stand there, not moving, barely breathing. Eventually, I leaned my back against a tree. She's looking at me concerned and unsure what happened. I told her I hurt my ankle. So she says, just put one foot in front of the other and try to walk slowly. I'll help you. I said, sweetie, I can't move right now. Just give me a minute. So my brain is finally recovered from the shock. Now it's time to take action. Can I stand on it? Oh, yes. Can I take a step, put pressure on the foot? Yes, I can. Yay, I don't think I broke any bones. So I'm self-diagnosing here. I slowly make my way to the edge of our shared driveway, assure my little neighbor I'm okay, and bid her good night. I'm almost home, 25 feet, 6 steps. Alas, I made it into the house. My foot is throbbing. My brain is in overdrive. What to do next? Get to the computer, find some answers. So I get on, search using the Edge browser, rolled my ankle. Results return, rolled my ankle, heard a pop. Can't recall hearing a pop. Let's see, next one, roll my ankle, and now it's clicking. Nope, I don't hear any clicking. Let's just check roll my ankle treatment. So under treatments, it reads like I have a sprained ankle. What's the severity? Grade 2 maybe? I don't know. I do see a note, call your doctor if you have a pain and swelling in your ankle and suspect a sprain. Self-care measures may be all you need, but talk to your doctor to discuss whether you should have your ankle evaluated. I skipped straight to self-care. Now, the goal is to reduce the pain and swelling. So it says rest, ice, compression, elevation approach for the first 2 or 3 days. I need some supplies, but I can't risk driving or wandering around in stores looking for items. So next search is on Amazon. I ordered a cold therapy boot and a lace-up ankle support brace. Yay, it's going to be delivered next day before 8 a.m. But until my cold therapy boot arrives, I hobble into the kitchen, pull 2 bags of peas out of the freezer to start my self-care treatment. For the next 2 days, I iced, rested, and elevated faithfully. The swelling is going down slowly, and it really hurts. But I can stand on it and walk down the stairs if I put my back against the wall and come down sideways. Day 3 feels a little better than yesterday. I think I'm good, no need to go to the doctor. I start some light exercises for strength, range of motion, flexibility, and stability. The irony here is we've heard about underrepresented communities, inadequate access, risk of not visiting the doctors. I have never been diagnosed with diabetes or hypertension. I do have health insurance, access to the Minute Clinic, online advice nurse, but I never thought to seek medical care. During my online search for information, I did read more than once, it's best to see a doctor immediately. I probably would have sought medical care if by day 3, I saw no improvement, but I did improve. I also read that treatment may take 2 weeks for minor sprains or up to 6 to 12 weeks for more severe. So I chose not to engage medical care, but to continue with my self-care plan, trusting my ankle will heal in 2 to 6 weeks. Was it a wise decision? In my case, it worked out. In 6 weeks, I recovered with no pain or swelling and a full range of motion. Thanks, Tammy.
Thank you, Denise. Melanie, each of us must act as an advocate for our own healthcare. Can you share some ways that you've been able to advocate for your own or your loved one's health?
Yes, thank you, Tammy. I am a little bit different from Denise. As I would Google, I am one of those type of people that I almost call the doctor for a little bit of everything. And I think that's just kind of how I was raised. My mom and I are advocates for our family. One of the examples that I have is I had an aunt that was diagnosed with breast cancer, and the doctor gave her 6 months to live. Luckily at the time, my mother was working for a big company and was talking to one of her coworkers and was talking about how she needs to get a second opinion for her sister. Luckily, that coworker took it upon themselves to say, hey, I know somebody that works down at MD Anderson in Houston. Let's see if we could get her in. my mom and I were advocates for my aunt. And as a result, instead of 6 months, she lived for 10 more years. Unfortunately, she did succumb to cancer, but however, by us advocating and saying, you know what, we want to get a second opinion. Is there a trial that you could do? Let's look at other options. She was able to be with us for another 10 years. So I am big, huge on being an advocate. I'm currently being an advocate for my stepfather as we speak. I had to make calls before we got on this call. You have to stand up for your health and also for the health of your family members. Sometimes, you know, people cannot go to the doctor afraid of the costs, may not have access, may self-diagnose like Denise does and don't feel like they need to go. However, there are times where just getting it checked out could, maybe Denise's ankle could have been healed in 3 weeks instead of 6. Maybe if my aunt went a little bit earlier, maybe her stage of cancer would not have been as far advanced as it was. Next slide. So like I was saying, you do want to speak up about your pain. You can speak up about your family's pain. You can even speak up about your friend's pain. I am a lot of people's emergency contact because that's how much I advocate for my family and my friends. I even have like their medication in the notes of their contact. So today I had to call the hospital or the ambulance for my stepfather. He was having shortness of breath. And because I do keep a list of his medication and everything that's going on with him, I was able to advocate and call and get someone to come and the ambulance come and pick him up. So I can't speak to this enough. It's something that's very important for you and your family.
Thank you, Melanie.
Thank you, Tammy.
Dr. Hines?
So then just on the other side, right? So regular care. The first step is get a primary care provider that you trust, right? Because none of us know everything, right? So in the same way, I have to have a mechanic that I trust because I don't know anything that's going on in that car. So if you're going to give me advice, I need to get with somebody who I trust. Get a primary care provider that you trust so that then you are willing to be open and honest about whatever's going on with you. And as part of that, there's going to be regular checkups that need to take place. Regular is kind of different depending on your circumstances. So for folks who have chronic diseases, by chronic diseases, I'm talking about the diabetes or high blood pressure or COPD, those kinds of things. Their regular is going to be 3 to 4 times a year, assuming that everything is going reasonably well, right? If you are lucky enough to not have any chronic diseases, you're still, young, spry, and 25, right? Living life, maybe you're a once a year kind of person. But whatever's your regular, that's what you need to be doing so that then you can get the preventative screenings. The preventative screenings, again, are things that are going to change based on your age, your risk factors, those kinds of things. For example, colon cancer, right? Colon cancer, that used to be that screening for colon cancer started at 50, but now colon cancer screenings start at 45, assuming that you don't have any other risk factors that indicate that you should get that done sooner. And getting those screenings is how we can talk about getting those diagnoses potentially earlier so that then we can intervene earlier and hopefully get better outcomes earlier. We talked about the importance of compliance and taking any prescribed medications the way they are directed to be used. And that also includes things like taking only your medications and not other people's medications, because just because it does something for someone else doesn't mean it's going to do the same thing for you, right? And then sometimes people want to use the methods where I'm trying to stretch it out because I feel fine and I only want to take it if I don't feel good. If it's something that you're supposed to be taking on a consistent basis, you may be doing yourself more harm than good by not taking it as prescribed. The other thing I'll say is side effects. Sometimes side effects are reasons why people don't take medications as prescribed, but that's when we get back to having a relationship with someone that you can trust. So you can speak to those side effects, and more often than not, there are other options that are available. Maybe there's something we can do to mitigate those side effects, but if we don't know, no one can help you. And then just being forthright and forthcoming about any either side effects, other new problems, even the things that it hasn't gotten to the point where it's keeping me from doing the things that I need to do. But lots of times we know something's a little not right. And that fear of getting an answer sometimes keeps us from going or speaking, but speaking up can be the difference between, having a better outcome.
Thank you, Dr. Hines. I want to thank all of our panelists today. I think that it's really important that we acknowledge that each and every one of us can advocate for our own healthcare, but the data that we provide at Inovalon, we are proud to say can help in these circumstances as well. So if we move to the next slide, we are going to talk a little bit about what it's like to work at Inovalon, who we are as an organization, as well as the types of benefits and job opportunities that we offer. So if we move to the next slide, the first thing I want to highlight, and this is a big deal, so we have always strived to be a great place to work. And the only way to do that is to really understand what means most to our employees. And so for years now, we have done what's called an annual pulse survey. We do it twice a year, in the spring and in the fall. And our participation rates are huge. They're at 92% normally, which tell us that our employees feel that it's important to share their experiences and their trust that we're going to listen and we're going to take actions on their feedback. Some of those actions have included enhanced benefits programs, additional paid time off, the development of our DE&I strategy, which includes diversity as one of our core values, and our commitment to it in the workplace. Our DE&I strategy allows our employees to feel they can belong, contribute, and thrive. But we didn't stop there. This year, for the first time ever, based on these record high levels of feedback from our employees, we expanded to a partnership with Great Place to Work. They're the global authority on workplace culture. And every year, moving forward now, our employees are invited to do an anonymous survey called the Trust Index. And this survey provides us with the opportunity to rate us on the employee experience. And so through Great Place to Work, we get feedback from our employees, and we use that to benchmark and to measure and how we stack up against other great companies and what we can do to continue to evolve our culture and our talent strategy in order to maintain this certification, as well as to truly be a great place to work. So we're proud that we've been certified as a great place to work. And we hope that you're excited to think about coming to work for a great place to work, such as Inovalon. Next slide, please. I'm going to pass it over to Spencer to talk about our benefits programs and the types of job opportunities that we offer here.
Thank you, Tammy. And thank you all once again for joining this discussion today and giving us some time in your day. As part of our Great Place to Work recognition, as Tammy mentioned, we also like to highlight our benefits package. Inovalon offers a very comprehensive benefits package that includes a variety of benefits that you can see here on the screen. And they're there to support you physically, financially, emotionally, and socially. Also, most of our benefits are offered a la carte, which means that you can pick and choose when you do choose your benefits coverage. So you can enroll in one, some, or all of our benefits. And always, as I'll talk about in the next slide, you can check out more on our benefits at the careers page at inovalon.com. Next slide, please. So at this point, you may be asking how you can join this wonderful Inovalon team. On this slide, you'll see there's a small selection of our many openings that we currently have. And as you can see, there's not only technology openings, we also have openings in other functional areas like marketing, implementation, products, finance, and legal. You can see all of our openings at any time by going to inovalon.com/careers, and it will give you an exhaustive list of all of our current openings. Additionally, we'd like to call out that we are participating in 2 upcoming Blacks in Technology Careers Fairs, one on August 11th, the other on October 13th. And this is going to give you some time where you'll be able to interact directly with members of Inovalon, as well as representatives from talent acquisition. And then finally, before I head it back to Tammy, I'd like to draw attention to the statement that you see at the bottom. We This is a statement that is also located on our careers page and each of our job postings. And it really is there to encourage each and every one of you to apply, regardless whether you believe you meet every single one of the qualifications listed on the job posting. We have a very, very strong TA team. They view every application through the lens of finding the best candidate for the role. So once again, thank you very much, and I'll hand it back to Tammy.
Thank you. So to close off today, we're opening it up. I don't know how this works, Dennis, on Zoom, but if anyone has any questions, we'd love to be here to respond to those questions in the remaining few minutes that we have today. We have about 10 minutes left. So Dennis, can we open it up to individuals' questions? Dennis, are you there? I can't hear.
Jordy, you should be able to talk now.
Okay, great. Hi, yes, this is such a great session, and I'm so glad I was able to attend. And thank you all to the panelists for like sharing your experiences. And being of African descent myself, also Grenadian American, like I could relate to some of those experiences that were shared on the slides as well as shared by the panelists. So I really do appreciate being here and listening to everything. So I actually wrote down like 5 questions, but I know we don't have as much time left, and I do want to give others a chance to speak. So I'll just pick out a couple that I have here. So just to briefly introduce myself. So I do come from mainly an AI and data science background. And I have been working in the healthcare space for a better part of 3 years, and in the AI space for a better part of 5. And I'm also looking for new opportunities as well, mainly in the healthcare space. So my first question is, does Inovalon have like any like artificial intelligence or machine learning or deep learning solutions that you guys are using for your data for like any type of prediction or classification, or maybe even like certain prognoses for certain diseases? So for example, I briefly worked with the Mount Sinai computational omics lab back in the height of the pandemic, and we were able to build a whole machine learning model for COVID-19 prognosis using certain biomarkers. So I was wondering if Inovalon has considered either like by yourselves or like working with like other healthcare clinics or hospitals to use like patients' data to like predict for certain diseases or pretty much any other types of health outcomes.
I can take that, Tammy, if you'd like for me to.
Yes, please.
Thanks for your question, Jordy. So great question, and absolutely, Inovalon is excited about the role of AI, machine learning in improving healthcare outcomes. I would love to say we have cracked the nut, but we haven't. Right now, we're working on using AI to shape some predictions within medical records. Absolutely. We also have a partnership with AWS, about which we're very excited, but we are absolutely early in the process. There is a tremendous amount of excitement, and certainly we know that there's opportunity here, and are pursuing it. But one of our strongest interests, because we have, I think you may have gathered that we have a strong interest and strong dedication to gathering data around social determinants, and we absolutely have the intention of using AI capabilities to use the data we're gathering now more and more effectively to predict those outcomes. So thanks for the question. That's what I have. There's a lot of excitement around this.
Okay, great. So glad to know that you guys are also topped on the train. I do believe like healthcare and AI pretty much go hand in hand at this point. So I'm glad you guys are already tackling that. That's really exciting. My other question is, so you guys like mentioned, especially like in the Midwest and rural South, that a lot of people are very hesitant to either go to the doctor or they're just like way too far away from like different types of like clinics and so on and so forth. So my question for you guys is, have you considered or are you guys already using like telehealth solutions to sort of like bridge the gap between like the patients or potential patients and the clinicians and the physicians? So for example, with my last job, we were actually like building like a whole solution around telehealth communications, especially during the pandemic where everyone was like at home. And we were also like using like wearables, we're considering like voice bots, chat bots, like in the whole AI space. And like using like other devices like a continuous glucose monitoring device so people could like just track things at the comfort of their home, and the clinicians or the physicians could chat back and forth between them, the patient and the and themselves, so that way they don't necessarily have to like be at the doctor's office. So have you guys like considered, or are you guys already like building out solutions like that? Yeah.
So I can take this one. So yes, similar to lots of other practices, we did stand up telehealth platforms during COVID, which we are continuing to use so that, to your point, we can reach not only folks that can't that don't have access, but again, telehealth also allows you to get at people who might be able to be at work, right? And then just find a safe space to conduct their visits. So then you don't necessarily have to leave work or find a babysitter or deal with some of the transportation issues, some of those other barriers that can keep people from going. Luckily, the climate across medicine is certainly opening up a lot more to some of the supplementary devices and techniques that you're mentioning, right? So whether or not it's glucose monitors, blood pressure monitors, the landscape in healthcare has significantly changed since COVID to allow more providers, specialty clinics, all kinds of ways. People are being way more innovative about how they're connecting with patients and connecting with providers. And it's also creating avenues to bring in some of the ancillary care folks. So sometimes now the family members and the caregivers can get in and get on board and give input using some of these other methods. People can stay at home instead of in hospital settings because of some of the ways that we can increase monitoring. So all of those things are happening both with Inovalon, but also just in the healthcare industry in general.
Okay, great. Awesome. Thank you so much for that. Really comprehensive answer, Dr. Hines. I just have one more question before I take it away to someone else. So last one, I'm actually curious about whether you guys, you guys sort of like implicitly sort of like talked about it when you guys were like introducing like the types of data that you guys were looking at, but I just wanted to get like more clarification if you guys were tracking like the quality of care as well as like the patient's experiences in the data. So as we know, like a lot of people of color have reported negative experiences and experienced like high levels of medical gaslighting from their physicians, from their doctors, as well as we know with like the Black maternal mortality rates with Black women as well. So I was just wondering if you guys are already tracking that, and how is Inovalon sort of like doing their own way of like rectifying those type of like large scale issues.
So I'll start, and anyone else who wants to comment is welcome. So Inovalon does a lot of work in the outcome space, in quality data for medicine. And a number of the items that you mentioned are measured in quality metrics across the country. So to the extent that they're represented in the claims data and in the electronic medical record, the answer is absolutely. Do we support our clients in patient surveys? Answer is absolutely. Can I state that we are adequately representing the personal experience, the concerns around medical gaslighting, that sort of thing? Are we gathering those data effectively? Not yet. Definitely an opportunity for us, and I think for the industry. As far as what we do to try to overcome barriers, during our encounters, during our in-home encounters where we either support a patient's own physician, I said in-home, so we might be sending someone to a patient's home for an encounter, or we might be supporting a patient's doctor in gathering information on social determinants. And part of the information that we gather through those encounters is barriers. Are you able to get your medication? Do you have access to food? Do you need transportation? So, and the information that we gather there, we then use to feed back to our health plan clients so that they can, again, target resources where resources are needed. So lots of work to be done. Those are the ways that we are trying to do our part, but we're also dedicated to the social determinant space, and to using, when I was mentioning that imputation where we were looking at the 9-digit zip code or the 5-digit zip code, whatever we have for a region, and using that to provide more clarity around an individual's overall health experience. We're using that, the conclusions that we're reaching, the information that we're gathering, to help our clients close those gaps. So that's the way we're approaching it at this point. Anyone else have other comments?
Did a great job, no?
All right. Thank you guys so much. Those were amazing answers, and I'm so glad Inovalon is just like in the space of like rectifying all these like large scale problems that really plague communities of color. So thank you so much.
Thank you.
Thank you, Jordy.
I see Michael Williams has his hand up.
Yes. Can y'all hear me? Oh, perfect. Well, I want to first and foremost say that I really enjoyed this presentation. My name is Michael. I'm a nurse practitioner. I'm actually here by way of Jamal Wilburg, who is a friend and who was promoting this event. But I got to say, it was very insightful. From this question, maybe more to Dr. Hines or Dr. Kilian. Dr. Hines, you mentioned, that implicit bias, right? And I think the overall theme is leveraging that data to improve on social determinants of health. I'm also from the family care background, internal medicine at FQHC, prior to sexual health now. So for y'all, how are y'all, I guess, utilizing the data really? Because when we talk about provider bias, implicit bias, right? In practice, the easiest thing to do is put that a patient's non-adherent to medications or to treatment. And, you kind of shift the blame to the patient rather than saying, as a provider, as a clinic, what more can I provide, right? And I think this data and the things that y'all are doing are useful for that. But I guess in practice, how are y'all supporting to improve on some of those inequities? Maybe is there any educationals that y'all do with providers to bring them more aware of how social determinants of health impact that clinical outcome, or in hypertension, diabetes, and all those things? So that's kind of my question in practice, or what are y'all kind of doing? Because I think this information is so useful. And if you practice family medicine, you know how hard it is to take care of the unhoused, to take care of refugees, or all these populations who there's many layers to get through before you can say this is true non-adherence to treatment, right? So.
Absolutely, and I'm happy to start, Jocelyn. So your points are great ones, Michael. The way that we're approaching it now is by driving awareness of the importance of social determinants of health, and gathering that information both from the physician and nurse practitioner side, interviewing patients, but also helping our clients educate their clients, who are largely someone's patients, right? To understand that they're going to be asked questions that are tough and that they might not be comfortable answering, that they might be suspicious of why someone wants something that seems to be financial information or other kind of intimate information that makes people suspicious that it could be used against them in some way. So our thrust is to is to acquire social determinants of health data through healthcare interaction and to educate patients wherever possible on the importance of providing honest answers so that those answers can be used to improve their health. So that's where we are at this point.
I would also just add to your question too, when we're talking about some of the ways that some of the implicit bias can show up. So, and I have an FQHC background myself, so I totally get what you're saying. In some of the ways that we present data to provider networks or to provider groups, or even, for example, a FQHC plan, for example, it can show at this clinic, we have 5 providers, right? This provider is having different outcomes than another provider, or let's say a hospital system. Our clinics in this zip code seem to be getting different outcomes than our clinics in this zip code. So in addition to using, for example, the information that Paige was talking about as far as social determinants of health, looking at those outcomes is going to kind of force a deeper dive. In addition, there are other metrics that are coming out. CMS is looking at starting at health equity index, which is also going to make some measures that are going to look at some of the disparities in outcomes and grade health plans kind of on where they are as far as in relation to their neighbor health plans. So there's incentive there to eliminate and deal with those risk factors. And then the other thing too is data is only data. Then we have to turn it into information, and then we have to turn it into knowledge, right? And all of that is going to be, when we see a difference, then what, right? What's the next layer underneath there? So to your point, right? Is it truly non-adherence? And is it non-adherence because there's no pharmacy for 45 minutes? So getting to, yes, I'm not adherent, but not because I didn't want to, but because maybe I don't have access or those kinds of things. Getting at those layers is where we kind of put all the pieces together.
Excellent. Thank you. Thank you, both of you all, for answering the question. Again, I thank you for the presentation.
Thank you, Michael. Are there any other questions? I know we're over time. I apologize. This is an important conversation. So if anybody else has any questions, we want to open it up for that. If not, it's been a pleasure meeting with each and every one of you today. Again, I want to thank all of our panelists for sharing their personal experiences. It's a very powerful conversation. So thank you all. And to everyone, enjoy your week.